hello. Hello, hello, good evening. I am excited to be here with you this evening. I'm excited about all of these, actually. Every time I'm on one of these lives, I'm really excited. I love the feedback. Please keep sending me the messages. Please keep leaving the comments. Please keep telling me that this is something that you actually enjoy me doing. Because that only encourages it to keep happening. And ultimately, I think that's what we all want. Here we are for another free weekly lecture. OMT lifespan. So we're going to go from birth to beyond. I didn't want to get too morbid, but birth all the way through the lifespan, and we're going to follow straight through. But before we get there, welcome, welcome, welcome. Whether you're watching a replay, please type replay in the comments. I'm going to tell you guys again in just a second how much comments help. Everything helps the viewage and the growth. So, welcome. If you're watching live, just give me a hi, hello, tell me that you can hear me, that you see me well, I'm not freezing or like choppy, because we have had some of those lives and we don't want to repeat that, okay? So welcome in. Incredibly happy to have you. Like I mentioned just previously, these are free weekly lectures. I talked last week about why I do these, and if we want to just keep them going, I think just support the channel. It'll be really great. Just like, subscribe, to the YouTube channel if you're on YouTube. If you're on Facebook, our Facebook community is a fantastic place where you can access all of the recordings like in one spot. Or if you're on LinkedIn, like the post as well there too. That helps additionally for views. All right. Awesome. All right. So now, quick little sidebar before we get in. If you want something a little more, or you're like, I wish these came with CEs. I actually have something that does come with CEs, and it goes a little bit more in depth. And so you can get some of my like advanced education. It's a little bit like next level stuff. Myomentality is a wonderful low cost membership that I have. It's $12 a month with CEs. If you do the annual plan, you save money. It's really a no-brainer. Myomentality.com. If that's something that you're interested in. I did get a message this week about, hey, I really wish you would do these and like offer CEs. Is there any way I can get you to partner with insert name of the corporation here? And I just really don't want to be controlled. I don't want anybody to tell me I can talk about this or I can't talk about this. I think many of you who know me or have known me for a while know that I used to be affiliated with other places, and there's a lot of restrictions on that, and we don't need that. We don't need that in our lives. I don't want that kind of energy. I want to give you stuff for free. I want to educate. I want to get better week after week after week, and that can only happen if it's free. So if you're looking for CEs, I do actually have a place where you could do that. Otherwise, let's just go into the nitty and the gritty. Let's get into Myo through the lifespan. So a lot of people, I was lecturing this week at the Florida Dental Convention for the Florida Dental Association. And the Florida Dental Association, I am so excited for the route that they're going. A lot of new and interesting topics. They even had yoga that was like sold out as its own CE, like participate class that you can have. So I'm really excited about where the field is going. I think they're really going to great places. The issue is that anytime I talk about myofunctional therapy, everybody wants to talk to me about pedo. It's so much more than that, and it has so many more applications and places where you can use it. So throughout the lifespan, myofunctional therapy is incredibly useful. But then top it off, there's things that do get progressively worse as you age, things that, are more difficult to change. And so I can see why there might be some resistance for adults or even older adults to myofunctional therapy. And we'll kind of dive into that a little bit tonight, but it is purposeful for every single age and stage. Now, first thing somebody's going to hit me with, but what about our scope? I know, scope of practice. You want to talk about whether or not myo can be applicable for babies. Well, just because babies can use better oral myofunctional, function, we don't want to eliminate the oral dysfunction that exists in them. And we can't really go there because a lot of that is within a feeding realm. It doesn't mean that they don't still have a need, or is there a lack of purpose for myofunctional therapy. Okay, so there's still the purpose, there's still the need, and we still do have a role to play. I'm going to tell you 100%, anytime I'm working with families, and I had an interesting question that was posed to me, and I'll tell you about that in just a second. But anytime I'm working with families that contact me with babies, very first step in my clinic, if you are going to engage with me in any way, shape, or form, you're going to request a consultation. Okay. You request that consultation. It's a complimentary consultation. They told me to stop saying it's free. It's complimentary consultation because I want to talk to you to figure out, like, where could you possibly go with this? It's supposed to be like a funnel, right? But a lot of times, I want to say at least a couple times a week, I get babies. Somebody who was born 3 weeks ago, a 4-month-old, 8-month-old, 11 or 12-month-old. I get families who have babies. And it's really important that I delineate that line because a lot of them are asking the question, my 10-month-old is mouth breathing and I don't know what to do. And I really need some help. And everybody says that I can't do myo. Like, can I do myo? And I don't want to do typed back answers and responses because there's so much I want to say to them and so many great people to guide them towards, whether it's pediatric feeding therapists, lactation consultants, pediatric ENTs, airway focused release providers or expansion providers, not for baby. You're not going to expand the baby, but you know what I mean. I want to send them down the path of somebody who's going to tell them, hey, don't let the internet get you all messed up in your head. Don't let it get you ahead of yourself. The baby is 10 months old. The snoring isn't great. It's not ideal, but baby will live. You are still a good parent if you let it just kind of play out a little bit until they're a little older and can do something functionally about it. In between now and then, nasal hygiene. I want you to make sure you're doing this, avoid that, yada, yada, yada. So you can give little tips and recommendations. And I think that's where the line really is as far as myofunctional therapists in a team modality, because a lot of these families, you're never dealing with you're hardly dealing with, I'm not going to say never, you're hardly dealing with just the one child family or just the person who only knows one person that needs it and they're not going to talk to anybody else about it. So even if there's an only child family and you're working with the child or working with the parent, they're going to talk to their sibling, friend, cousin, like somebody, and they're going to tell them about it. And then that person is going to wind up on your schedule or calling you or contacting you and wanting the same or similar kind of help. So myofunctional therapy has a role, and there's a lot of stuff on this slide right now that I'm not talking about at all. Thank you guys for dealing with my rants every week. But there's a lot of stuff that myofunctional therapy can lead others into without having a direct, like, we're working on proper oral resting posture with the 4-month-old, if that makes sense. Like, shoot me a yes, that makes sense. Now, when it is that baby to toddler phase, and I'm thinking, we're really talking about maybe birth to right around 3, 2.5, perhaps. In that early stage, we're talking about all nutritive skills. Like, that's where you're going to see a lot of the problems. Will you have other issues with respiration, with, respiration, I've already mentioned, with eczema, with digestive issues? Sure, there could be a lot of other things going on. Typically, where you're going to see it is that the parents are going to be like, oh, my latch, my breastfeeding didn't go very well, or we struggled with this, that, and the other. The feeding isn't going well. They're not accepting certain foods. I'm having difficulty transitioning them to solids. My kid is gagging on everything. I don't know what to do. All of those are feeding issues. Feeding issues that I don't know as a non-feeding therapist whether or not they can be, but I'm sending them absolutely to some of my favorite feeding therapists because some of these things can be remediated with some functional work on feeding, the approach for feeding, the tools for feeding, just working with the oral motor skills in feeding. They're specialized in that area, and that's kind of where I leave that for those issues. Will you see oral myofunctional disorders in babies? Sure, absolutely. You're going to see different things. You might see the open mouth posture, the low tongue, oral tissues are going to be the big one. That's where myo really has a role. I am a huge proponent for not sending families with infants directly to the laser operatory. Okay, do not send them directly. Oh my gosh, little Jimmy has a tongue tie, you better get to the dentist today. Great, you go to the dentist today, you're already all worked up in your mind about what this procedure is going to be. There's going to be a laser in your kid's mouth. Lord knows what that means to you. Okay, because everybody doesn't see it the same way as us as professionals. So there's going to be a laser in your new baby's mouth. And then after that, you're going to have to get into their mouth and you're going to have to manage that open wound. And you're going to be in their mouth while they're screaming and crying, doing stretches for weeks. That's absurd. It's absolutely absurd to take a new family, a new parent or new parents with an S, and kind of throw that burden on them on some really like hyped up, oh my gosh, I've been told if I don't, this, and this will happen. I don't know about everybody else. My crystal ball, it doesn't work that way. I have no idea whether this tethered oral tissue will manifest in a guarantee of speech issues, a guarantee of sleep apnea, a guarantee that you'll be a bedwetter. Like, who are these people that are scaring these new moms and why are we doing it? So I feel that what we need to do as myofunctional therapists and in the role of myofunctional therapy is to start advocating for infants and infant families, birth to toddler phase, that they go see a myofunctional therapist prior to even considering that they're going to do a release. Okay. Yes, they can go to the release provider if the release provider is going to charge a consult fee for their time, right? That way they can see, they can confirm, they can diagnose, because as a myofunctional therapist, we do not diagnose. We assess for function, but we never diagnose. Okay. They can go there and get the diagnosis if you absolutely positively need that. But I'm telling you right now that almost everybody can see when it's pretty overt, right? When it's more like up for grabs, like is it not? Sure, you go see the release provider. But that's only for the consult. The release provider should direct you to your nearest myofunctional therapist, okay? That myofunctional therapist is going to sit with the family and do all of the things that your release provider does not have the clinical chair time to do, to sit down and to explain to you what this process really looks like, the nitty and the gritty. We're going to practice holds. We're going to practice stretches. We're going to do fun, engaging sort of things that you can do to stimulate different types of movements and to kind of help to facilitate a little bit of the baby helping you help the baby. Sure, we're going to do some of that. But you're not going to get any of that and the time to practice if you just go straight for a release. So what you need is that time to really sit and to say, okay, let's hold. All right, we've got our hold. Baby's crying already in this hold. Maybe baby doesn't like it, or baby might be swaddled, and maybe baby doesn't care. Baby's enjoying life, right? Now, you've got to get in there. Not everybody wants to be in people's mouths. Like, please start accepting that as a general rule. Not everybody wants to be in anybody else's mouth. Some people don't even like being in their own mouths, okay? So now, what kind of tools? I like finger cots. Some people like gloves. Some people are really about, okay, I'm going to wash my hands 3 times and then I'm going to put it in my baby's mouth because I'm really a germaphobe and I don't want to have da-da-da-da-da. Okay, let's get that whole routine going. We're going to get in there. This is the hold. Am I holding it right? Yes, mom, you're holding it right. No, fix your positioning. Like, we're going to get that all together. Baby is screaming. There's no wound. No wound. It's just you're in baby's mouth. If you were to put your fingers in my mouth and you just start pulling at my tongue, I'm going to scream, okay? I don't need a wound to scream, but you get accustomed to this. So now you've got the grip, you understand the holds, you're ready, you're preparing, you're doing this once or twice a day. You really feel like, okay, we're in a groove. I get it. Now, when baby's crying, it's not out of just like, oh my gosh, what did I do? There's always that immediate regret. I haven't spoken to a family yet who's contacted me post release who didn't have immediate regret. What did I do to my child? Why did I do this? Why did I think I could do this? Maybe I should have waited. None of that happens when they practice beforehand. Okay, so you want to get them a little bit of, prior experience. That way they feel more confident and you get better results, right? So myo's role, tethered oral tissue, is incredibly important. A lot of the other skills you're going to see, it's going to be more feeding therapy. And I'm going to tend to agree with all the professionals who are saying that that's 100% in the realm of the feeding therapist. If there are structural concerns you have, like, oh, okay, I think that there's issues with the tonsils, the adenoids, I think baby's mouth breathing because, etc., send to a pediatric ENT. You weren't going to be able to do anything functionally with myofunctional therapy if adenoids are enlarged in the infant anyway, if adenoids are enlarged in the toddler. If it's enlarged in like a child or an adult, you're not getting much progress anyway, right? So pediatric ENT. So a lot of sending out when it comes to birth to toddler age group, or making recommendations. What's the functional purpose for a sippy cup? There is none. It's all about just preventing spills for mom. Mom doesn't want spills. Sippy cup, perfect. It's really, you can make the transition. You don't have to wait. If there's delayed skills, motor skills, then that's ENT, PT, not ENT, OT, PT. That's more of a refer out. So we do a lot of recommendations. Are there needs? Absolutely. Are there needs that we can fully address? No, with the exception of tethered oral tissues. Okay. So I think it's incredibly important to acknowledge this age group as important and very relevant, and all of the information that we get as we go through other lifespans. Like if I'm talking to an adult and I want to know what happened, early birth history, early feeding, motor skills, and so forth, it's all to kind of put that picture together as to how we got here, how long have these things really been ignored, how long have they been compounding, but it's important information. It's just not anything we can really, really touch on as of yet with this early group. Okay. Awesome. Okay, let's move on. So preschoolers, I love. They're some of my favorite. Last month, or maybe it was the month before, I don't know, when I came out with the Myo Mini thing. So I had this Myo Mini $7 resource where families for children that were between the ages of like 2 to 4, or I think it's 2 to 4, it was marketed for, something like that. You can do fun little games. And I have never gotten so much positive feedback than all the people who do these fun little like games and exercises with their children. You really can make good changes in this group. Here is the problem. The problem is a big problem. They're not cognitively, developmentally and ready yet to do a full myofunctional therapy program. So you're not going to get to proper oral resting posture, to habituation of new skills. You're really not going to get there. You're just really going to create a foundation upon which maybe when they're older and they're cognitively or developmentally ready to really get more gains and develop habituation across their lifespan. Okay. But this is a really good age to start working in, because guess what? A lot of growth and change is happening. And this is when things that impact change, like those kids in preschool with the sippy cups still, the preschool kids with the habits, those parafunctional habits. So their digit sucking, their thumb sucking, lip biting, cheek chewing, cheek sucking, and they're doing all the things, tongue sucking. That's a really prevalent one. They could be tongue sucking. They're doing all of the things. When you get these age groups, you can make changes that you'll actually see manifest as like change in the body, right? So if you've ever had a thumb sucking preschooler, and I don't have to tell dental professionals, when you take that thumb and you make that impression on the roof of the mouth, on the palate, it's going to change the shape of the palate. I don't have to tell you that. So you understand soft tissue pressures and how all of that can directly impact the shape. When you take that thumb out and you start to see like, oh, mom or dad, and you're recommending that, yes, they start to eliminate the habit and you're giving them recommendations and so forth, you start to see that once they just remove what was there, you're going to start seeing shifts and changes in the teeth, right? Like you'll start to see that little arch that may have formed, or those anteriors look like they were going upwards, just holding space above that thumb or digits, whatever is in there. You're going to see that starts to kind of normalize, right? So this is a fun stage to really do myofunctional therapy in like its most bare bones manner because you're going to see the effects. I can work with an adult for a couple of months before I see some effects. I can work with like a 3-year-old for a couple of weeks, and we're going to see some changes that happen what feels like overnight, but it's clearly not overnight. So all of these things that you start to see, and then you start to see things that maybe weren't addressed earlier in that birth to toddler phase, like asthma or eczema, allergic dermatitis. There's a lot of studies that link the two, okay? So oral respiration and allergic dermatitis, go PubMed it. It's a thing, right? You want to be respirating appropriately. Otherwise, you're more likely to have things like eczema. You're more likely to have symptoms of asthma. You're more likely for these things, just like you're more likely for obstructive sleep apnea or snoring or whatever. It just increases the likelihood, doesn't guarantee it. It's one of the manifestations, okay? Preschool, a lot of developmental needs at this stage, and it's a wonderful time to work with them. OMT or they're just really not ready. They can follow simple commands. They can probably do 2 to 3 step commands, but you're not going to get them at any kind of stage above that where you can give them complex directives that will get them to start to coordinate oral function in the way that we would like to eliminate compensatory patterns. Okay. So they're not really ready. You could do a mini program. I do a mini program. I sell that email course online. It's $7. Families like it. And then most people need more support. And when they need more support, then they contact me and we do like a 6-session small thing. And we just kind of keep going with it. It's really, really fun. If you're looking to learn more about this age group, let me know. I've got the best course for you about it. This is also a fantastic time because of the craniofacial development. By age 4 to 6, approximately 60% of the craniofacial development is complete. What does that mean, Carice? Great question. So glad you asked. It means that a lot of those sutures have started to come together. Like you've had a lot more flexibility up to this point. And so the soft tissues could have influenced some more of that development and then changed the position where some of those sutures started to fuse in the cranium. But at this point, 60% of the development is complete. And so you still have 40% that you can influence, but it's no longer the majority. And so it's really nice to get in there with the preschoolers and to do something introductory with them because you know that you're on the early end of making change and that you can really help them. If avoid braces, I hope you're only working with 2 to 4-year-olds because that's probably your best chance at avoiding them. Outside of that, you're in the minority. So I don't know how much change we're doing with just soft tissue alone, which kind of leads me to where we go next, childhood, adolescence. I love this photo. This is a stock image, by the way, but this is like the cutest stock image for myofunctional therapy lecture, because just look, you can see the oral dysfunction. You see it. It's just right there, the craniofacial development. Like, I just see all the issues, and I'm so excited about it. I wish I knew him for real. In childhood, all the way through adolescence, now we've got some foundational growth. Now other providers are starting to step in. So when you're talking to a family with a baby, with a toddler, with a preschooler, nobody is listening to you. Their pediatrician is like, they'll grow out of it. The pediatric ENT is like, nah, they're fine. I don't want to scope a 3-year-old. It's cruel and unusual. You've got your orthodontist saying, no, they're too young. You have to be really, really blessed to have a functional provider in your area that is treating early with airway orthodontics or interventions, treating malocclusion or, those palates, and are really getting in there at age 3, some of them as young as 2, but 3 is like more the average, right? So when you come to childhood, adolescence, it's a wonderful turn because now people are listening. Now you're more likely to get a scope because the kid's going to be probably more compliant. That's not to say that all ENTs are great at scoping. You really have to know the difference between ENTs and know who it is you want to talk to, who it is you need to work with in order to get the best results and outcomes. But the collaborative potential is all there. So you're going to see a lot of issues that will start to pop up, and parents start to realize, they're like, oh my goodness, they have these social or emotional or behavioral issues that pop up at school, and I don't know what to do with it. Or now we're starting to see those signs of ADHD when they are or ADD. When they are a preschooler, we're more likely to ignore that and they get a nap time. I mean, life is sweet as a preschooler. Then you get into kindergarten and it's a bit more serious. Like, they want you to actually learn things and like retain that information. Like, whoa, it just blows your little 5-year-old mind, right? So then you really start to see the manifestations of, well, what's life like without having that period of rest, without being able to really restore in the middle of the day, to have these longer days. I mean, we expect in some places the kindergartners to maintain the same length of day that other elementary school children are maintaining, and they might not be quite ready for that, especially if they're not sleeping at night, right? So losing that nap time becomes incredibly big. Because the restorative sleep is just not there, okay? The orthodontic treatments are ready to start. Now you're able to get good focus. Parents are on board. They're like, we see the issue. The crowding, the teeth are starting to come in. Now they've got that sharp tooth thing going on. Like, now it's really, really prevalent, right? So as this dysfunction starts to compound structurally, so you're seeing the manifestations physically, and then behaviorally, you're seeing the manifestations there too. That's when now you're like, oh, I got to do something. And they're ready for it. They're ready. They can own the early stages of what some goals are. I've had some kids in really young phases of this childhood range. So childhood, adolescence, you can think of like teen and so forth. So early childhood, like 5, 6, 7-year-olds who have really owned their part of a myofunctional therapy program, because it's a big commitment. It's daily exercises for months on end, right? If you are experiencing something adverse, and I don't like that. I don't like it for any of the children, but those are some of the most focused children that I have in these programs. If you're experiencing something as adverse like bullying, or you're being isolated because you have like Bugs Bunny teeth, or because you look a certain way and your teeth are crooked, like if you're experiencing that, there's nothing more that you want than for that to stop. And when they own that that's why they're doing these exercises, they're doing those exercises pretty religiously. Mom and dad might drop the ball, the kid never does. And so they're more developmentally ready to have some ownership over it. As you see them get older, the preteens, the teens, they can definitely have more ownership of it. But typically you find with the children and the adolescents, it's, you know, a little difficult and challenging in some ways because they're not paying for it. Like, what do we care? Right? I didn't pay for it. I'm not concerned. Like, I lost my cell phone, you know, that's a big concern for them, right? They don't pay for that, but they want to know where their phone is. But the myo, they just don't own it. But they are ready to do it. So they can finish a full myofunctional therapy program, right? And then as we tiptoe into adolescence, we've got some hormonal changes that will start to amplify what's going on. So now we've got this cycle that might happen monthly, or we've got some changes that hit really hard and might impact directly what's going on as far as their sleep and how they're regulating through the day, their energy levels, daytime fatigue, kind of follow them and what's going on a little better, and we get clearer answers as to what the manifestations are, as opposed to those younger ages where we're kind of just tiptoeing between, okay, what's a dysfunction and what's more of like just a bad habit that they haven't really broken yet. And so childhood, adolescence. Okay. Under 21, you still got some growth potential. Granted, by the time you hit about 12, 13, most of that growth potential is already gone. But we do have mandibular growth that happens and can happen through to 21, 22. So OMT under 21 is still great because while they're doing all the changes with their functional provider, not functional, we're the functional providers. With their structural providers, like the orthodontists, while they're going through all of those changes, we're actually there to help support in the soft tissue pressures that we influence in a positive aspect is going to help them progress through that treatment much better. Okay, so now they're owning a little bit more of their outcomes and they're progressing through much better. Let me just check really quick. What do we have in the chats? It's so annoying when the DDS sends a patient with a tongue tie and then they go to the ENT and they say no, and they don't need a release. It's definitely crazy when they are a class 3 or grade 3 and and they're just denying it. But I would say 100% you want to just keep advocating for yourself. If I am going as like the myofunctional therapist, if I'm going to talk to the family about it, I'm going to say you want best out of 5 then. If I've said yes, if the dentist says yes, that's 2. ENT says no, that's 3. Okay, so that's 2 to 1 out of 3. I would go for another 2 if you're really on the fence. If you're like, I really trust the ENT's opinion, awesome. I trust the ENT's opinion too. Let's see what another doctor or professional has to say. And I think sometimes that really can help. So hopefully that helps you there. Adulthood. Now we're getting into the nitty and the gritty because now they're done with all that growth. And now we're starting to see everything as it's starting to compound. So potentially they had orthodontic treatment as a teen. Maybe it went on for years. Maybe there were extractions. Maybe there weren't. And then things maybe are starting to relapse. They're starting to see new things happen with their body that they didn't see happen before. They're starting to notice certain things and what's happening. Like everything is changing. More gastrointestinal issues. Maybe we're bloating more. We feel more gassy. We have, IBS. Maybe more is happening. We're starting to notice it because all those years of just kind of it being neglected, it compounds, it grows. So a lot of times when people talk to me about myofunctional disorders, I say, they don't just magically go away. They sit in the silence and they will compound. So it's just like if you don't get any other diagnosis, it doesn't make whatever it is just go away. You have to actually treat it in order for it to be something that you can eliminate. So while it's there slowly compounding, you're going to see the manifestations more. You're going to start snoring and you've never snored before in your life. You're going to start seeing all of these changes where now you have brain fog and you can't understand what's going on because you used to remember things so sharply and now you can't. And you're having all of these issues And now we start to see a shift. So yes, the shift between, our generations of the boomers, the Gen X, the millennials, the Y, and the Gen Z. There is a between the value for healthcare. Gen Z isn't there yet. Y and millennial are very purported to be up, but even Gen X is purported to be up too with their care and value for wellness. So as they get older, you start to see more changes and you want to get better results. So the adults who are going into orthodontic treatment after having it once or twice as a child, these adults now are more committed to we're going to get to the root of this. So if my orthodontist says I have a tongue thrust, guess what I'm resolving? My tongue thrust. Meanwhile, if you take that back to when they were a teen, you'd be like, I don't care about the tongue thrust. I just want my braces, and you didn't give me the rubber bands that are the color that I want. And maybe that's all they care about, and or taking off the braces. I think that's a big day for most teenagers. But when you are talking about adults, they're going to have that ownership for it. They're paying for it most likely. They want the outcomes, they want the benefits, they want to get to the point where they're autonomous. They don't need a myofunctional therapist. They don't need an orthodontist. They don't even want to need a physician. Okay. We need to have just wellness visits only. We want to be healthy. There is a big study that was done in 2022, and over 80% of the population, it was a national US study, over 80% of the American population would like to see more holistic and integrative services. And I really think that myofunctional therapy, yes, there's been a boom in the last 5 years. I think that there's going to be bigger booms as we get further into, this wellness movement, because this is something that does get to a deeper root issue. So myofunctional therapy becomes more enlightened at this phase, but we start to see more official diagnoses that are associated or can be associated, high blood pressure and so forth. Like, we're seeing all of the things as they come together. Then we got our geriatric stages. Isn't it just the cutest, like, old man? He is just like adorable. I love him. I also stock photo. Okay. Geriatric stages are absolutely wonderful and they do well with myo. Here's the thing. If you've had a dysfunction for 50, 60, 70 years, is it going to be easy to fix? No, it's not going to be easy to fix. They say you can't teach an old dog new tricks. That's a lie. You can teach an old dog new tricks. You can teach someone in their later stages of life to have new functional habits. However, it's not going to be as easy as teaching their grandchild. Teaching their grandchild, it's going to move like this, really fast, really quick. You're going to see changes, and we have the ability to really, push through it. Whereas I can't wait till the day since I was 25, I've wanted to be 55. There's nothing I want more than to live in an active adult community. Like, I can't wait for that lifestyle where it's like, I don't care about anything. And I feel like that attitude is very pervasive. Like, I want to be able to say whatever I want, feel whatever I want, and just like do what I want, and just be like, I'm old. Like, so what? Like, what are you going to do about it? Right. I think that it's a very pervasive attitude. And so, yes, they do great for myofunctional therapy, but a lot of them don't want to commit to myofunctional therapy. Like, look, I've been like this my whole life. You really have to sell me on this as far as something like I need, because I might be on a fixed income, or I might be trying to get to retirement, or I might be helping my adult children who had to move back into my home. I hear a lot more of that lately. Our geriatric stages, they prefer something more passive, something more abbreviated, something that's like a resource, as opposed to like, we're going to do a full oral myofunctional therapy program. I had some really great questions at the Florida Dental Convention after my lecture on myofunctional therapy about geriatric patients and what to do for them myofunctional wise. And I said, really, don't try to push the myofunctional therapy programs. Just don't. Part of what I do, you see me doing lectures here. I also do lectures. I live in South Florida. I am surrounded by communities that are active adult communities and those that are assisted living and so forth. And so I do lectures in many of those places. And when I'm doing these lectures in these places, I'm talking to them about ways you can improve your sleep and how important it is that you manage your nose and nasal hygiene and your breathing and whatever. And as many of these people, and I love them so dearly, there is no one closer to my heart than like old people. They don't want to hear about any myofunctional therapy. There's the occasional person, yes, and there's a whole lot of wealth in, you know, the communities that are on the outlying portions of this state. So there are people who will happily just throw some money at it to try to get it to see if it'll help. But most of them are kind of like, yeah, let's just do something more passive. So my advice, Myomunchie, fantastic, wonderful thing to try to use, just as you would use anything that you would kind of recommend in that preschool stage. I would kind of just double down on that geriatric stage. That's kind of where I would go. You want my Myo Mini program? We could do that. And they'll be more than excited to do that. There's just a lot of changes. Everything's happening. So whether it's a change going from working to now you're retired and you're managing that and you're managing a fixed income, or you're managing the changes that are happening in your body for women, particularly as you get into postmenopause, and where your body is there and what hormones and how everything is shifting and how you feel. And you're already going to have changes in sleep. You're going to have changes in some of your medical conditions, things that weren't that bad or things you didn't know about now have become more pervasive. If you didn't have something addressed prior to this stage, it's now like hyper amplified. It is much more intense. Okay. So for our geriatric stages, we're, I think, a little bit more toned down. They still have needs. They have the same needs as most adults do. They probably would like a root cause solution, but if it ain't covered by Medicaid, I don't want to hear it. Medicare, sorry, I don't want to hear it is very commonly something I hear in this age group and population. If any of you are experiencing something different, please let me know. I would love to come move to wherever your state is, because the people out here, they're living their best life in this Florida sunshine, and they just want quick, simple, fast solutions. OMT for adults. Okay. I kind of said a lot of that OMT for adults issue, you know, shorten the program for geriatrics, full program for like regular adults who are fully capable and not senior citizens as of yet. They have a lot more ownership of the program, but you're not going to see the results as rapidly as you would for children. And then you want to work multidisciplinary. I don't care what age they are with adults, you're always going to be working with someone else. So whether it is a manual therapist, a structural provider who is going to do some appliance therapy, whether that's an oral appliance, mandibular advancement device, or something that's going to be expansive in nature or more airway focused, awesome. You're going to be working with some other types of providers. Okay, so anticipate that for your best outcomes, they're going somewhere else in addition to your oral myofunctional therapy. But for the most part, I think that there is an application for myofunctional therapy in every single age group. It's all just a matter of how you want to view it, right? You can view it more for the positive, that there are a lot more needs in adults, even though it doesn't manifest itself as rapidly with the results. You can say it's more fun with children. Who knows? I think it's more fun with children, but it's also more educational. I learn more from the adults I work with than from working with the children, to be honest. There's a spectrum of growth. There's a spectrum of progress. And I think you can get there with any patient at any phase, at any stage. You can even guide infants and families with infants to the appropriate people that will set them on a better trajectory for optimal growth. It's just a matter of how you're really viewing the whole situation. I was hoping this was going to be a half hour, but I went on my nice little rants, but we got 45 minutes out of it. I think that is super duper good. I am going to check in the chat, see if if there are any comments or any questions anybody might have about how to utilize this when you are working with. There we go. Are we back? Awesome. Okay. Yes. So when you're working with those various age groups, any questions at all, I don't see any. Feel free to leave questions in the chat. I appreciate you all. Thank you for stopping in, and I will adios.